All right. Good afternoon, everybody, and welcome to the Durham University Wolfson Research Institute for Health and Wellbeing public lecture. This is Sadly, the ESA director from Wolfson. So this is the second in our series, having been preceded by a talk from our Ping Challenge Academic last month. The video for this lecture can be found on our website. So we would like to record also this lecture as a resource. So if you have any issue with this one, so please do reach out to Susie Boyd on the chat with your objection. In addition to the video of past lecture, you will also find the dates and registration detail of our forthcoming lecture on our website. So our next lecture on December 1st is from our Brain, Body, and Behavior academic entitled Your Headache and What It Says About You. Today, we welcome Professor Helen Ball from Anthropology and Director of the Durham Infancy Sleep Centre. Helen's work spans the aims of two of our challenge academy, both youth and women, as she studies infant sleep and the parent-infant sleep relationship from a biosocial perspective. Having obtained her PhD in anthropology from the University of Massachusetts in 1992, broadly defined, her research examines sleep ecology of infants, young children, and their parents. These encompasses attitudes and practices regarding infant sleep, behavioral and physiological monitoring of infants and their parents during sleep, infant sleep development, and the discordance between cultural sleep preferences and biological sleep needs. Helen has conducted research in hospitals and the community and contribute to the national and international policy and practice guideline on infant care. She pioneers the translation of academic research on infant sleep into evidence for use by parents and healthcare staff via BASIS, the Baby Sleep Information Source website. She served as the associate editor of the journal Sleep Health and is also on the editorial board of the Journal of Human Lactation. So she is also the chair of Lullaby Trust Scientific Committee and also an elected board member of the International Society for the Study and Prevention of Infant Deaths. In 2013, Helen received an award for outstanding impact in society from the Economics and Social Research Council. And in 2018, Durham University was awarded the Queen's Anniversary Prize for her research and outreach on parent-infant sleep. So more recently, Helen and her team has just been awarded an NIHR open funding grant to build on their previous work in sudden infant death prevention to improve outcomes for the most vulnerable babies. This will happen through training and supporting drugs and alcohol services, adult mental health services, and blue light services to engage with the family through collaboration with the County Durham Director of Public Health and County Durham Child Death Overview Panel. So ladies and gentlemen, without further ado, I will pass you over to Professor Helen Ball. Thank you, Helen.
Thanks very much, Zach. That was a very comprehensive introduction, so I probably don't need to give my talk now. Okay, so what we're talking about today then is how baby sleep conversations in the UK have changed over the course of the last 20 years or so, and how the research that we've been doing at Durham has contributed to this, or hopefully contributed to this. So for those of you who don't know us or haven't had much familiarity with us in the past, the Durham Infancy and Sleep Centre was established in 2000 after we'd done about 5 years of research before we formed the centre on parent-infant sleep. And originally we were called the Parent-Infant Sleep Lab, and we were based at the Queen's campus in Stockton. We moved up to Durham in 2018 and we rebranded as DISC, the Durham Infancy and Sleep Centre. And you can see here on the right, we're located at Hilton Cottage, which is down by the racecourse, or the cricket ground, old racecourse in Durham. So the Durham Infancy and Sleep Centre then is home to a team of anthropology researchers who study babies, sleep and infant care issues. And over the years, we've been involved in a number of different areas of infant-related sleep. We started off really in SIDS and sleep safety, especially bed sharing, which I'm going to talk to you about in a minute. which led us into the relationship between breastfeeding and sleep, and again, the role of bed sharing in that, but in a slightly different way. And that led us into considering how you might devise and test risk minimization approaches to SIDS prevention, and which led us into thinking about how we normalize infant sleep and support parents to manage their baby's sleep in the ways that are most effective for them. So our research has been used in various ways over the years, and we created the Baby Sleep Information Source, which is a website, a training program, an app, a bunch of downloadable resources to help health professionals convey some of this information to parents, and to help parents who are interested in kind of reading more about it go and find that information. We've worked particularly closely with Unicef Baby Friendly Initiative and the UK breastfeeding support organisations, all of whom came on board with us for the Baby Sleep Information Source. And we've also worked with other organisations that are involved in this space, the Lullaby Trust, the Scottish Government, various NHS trusts, and NICE, the National Institute for Health and Care Excellence, in their safer sleep guidance. So I'm going to probably mention all of these things as we go through this talk, but I'm going to begin by explaining how we think about babies. And really, our work happens in the space between theoretical perspectives of evolutionary biology and practical aspects of nighttime infant care. And by that, what I mean is that evolutionary understanding of the biology of babies and babies' sleep development over the course of the first year underpins the way in which we think about how parents and babies interact at night. So this evolutionary perspective then goes all the way back to our origins as mammals, because one of the key features of being mammals is the fact that we produce milk for our babies, and breastfeeding drives a lot of the things that happen in the early months of infant sleep. We're also precocial mammals, which means that we have to feed our babies frequently and need to keep them in close proximity in order to be able to do that. And that doesn't stop at night. And because we're hominin mammals, our evolutionary history has put some constraints on prenatal brain growth. So our babies are born with relatively undeveloped brains compared to other mammals, particularly other primates. And that is in large part because of the next step, which is, as modern humans, we have these unusually extremely large brains, and our baby's primary job in the first year of life is to grow its brain. One of the ways in which that's facilitated is by spending a large amount of time in active sleep. So babies spend more time in active sleep in infancy than they ever will during the rest of their lives. We're born without a circadian rhythm, so that has to develop over the first year of life. And there's lots of things to do with brain development and maintenance of homeostasis of various physiological systems that babies accomplish much more effectively when they're in close proximity with a carer during those early months than they do if they're separated. So that means that the needs of neonatal exterogestate just means that you continue developing in a fetal kind of fashion for the first few months after you've been born. The needs of babies who are kind of like born in that helpless, immature state conflict with the expectations that we often have of babies in contemporary Western, educated, rich societies. So that brings problems, difficulties for parents in how to negotiate their baby's needs and the demands that are placed upon them. So our approach to what we call biologically normal parent-baby sleep then involves helping people to consider this intersection between evolved infant biology, as we've just talked about, and culturally determined patterns of nighttime care in Western societies, recognizing that this produces a conflict between the parent's needs and the baby's needs, and the fact that the ability or the willingness of the parent to meet their baby's needs at night can help us to understand the ways in which parents manage nighttime infant care. And that's basically what we've spent the last 20 years trying to study and understand is, how does that tension between the needs of the baby and the parent's ability to meet those needs at night play itself out in different sleep scenarios? So when we began our research, we were interested in this question of, what do parents do then with their babies at night, given what we know about evolutionary biology, but we also know about the circumstances in which babies are being cared for in Western societies. What are parents actually doing? How much variation is there in nighttime infant care? Why do parents choose the sleep strategies that they implement? How do they implement them? And what trade-offs are they making in nighttime infant care? And overall, what we wanted to do, because this is obviously very applied research, we wanted to use it to understand how we might improve policy and practice in this area for parents and babies. I think I've just skipped a slide. There we go. So one of the things that came out of our early research very, very strongly was the issue of sleeping with the baby. And what we found from talking to parents, doing interviews, doing surveys, doing focus groups, that always came up was that bringing the baby into bed is a very common nighttime care strategy that lots of parents in the UK use, even though when I first broached the idea of studying this in the UK, people said to me, well, why do you want to study that? Nobody in the UK bed shares. My parent network, my own parent network told me otherwise. So when we actually started talking to parents about it, it became clear that it was something that a lot of people did. It just wasn't something that they talked about. So our research explored who bed shares, how they do it, why they do it. We identified why it might be practiced more or less safely under different circumstances. And we highlighted the importance of how practitioners talk to parents about it, because you can completely close down conversations and stop parents from telling you anything about what they're doing by approaching it in one way, or you can have meaningful conversations with parents about risks and safety and all of that kind of stuff if you ask these questions in another way. So we explored parent-infant sleep behavior then, and particularly this aspect of where babies sleep in homes, in hospital postnatal wards, and in our sleep lab. And the results of this research has informed public health guidance, it's informed hospital policy and practice, it's informed information for parents, and it's actually contributed to international debate about bed sharing safety over the past 25 years. And it also led us into research that asking the question of whether the sleep of breastfeeding mothers and babies actually differs from that of non-breastfeeding dyads, and what normal infant sleep actually entails. What should be our benchmarks for normal infant sleep? How should we help parents understand whether their baby's sleep is normal or not? So I'm going to talk a little bit, because we don't have a huge time for this lecture. I'm going to talk a little bit about how guidance and practice has changed in response to the research that we've done and the outreach that we've done. So how have these conversations changed over the years? So I'm going to talk about 5 things. One is the provision of bed sharing information to families, particularly for breastfed babies. Another is the adoption of sidecar cribs and bed sharing policies in hospitals, and a growing acceptance that separation at night isn't beneficial for mothers or babies. So how can hospitals manage that in the early postnatal period? The recognition that aligning babies' needs and parents' lives means that parents' sleep strategies vary, and why they vary, and why we should expect variation in that, and how what people are doing is not necessarily wrong. They're doing what works for them. So we need to be accepting and understanding of all these different sleep strategies. I'm going to talk a little about the incorporation of our work into some of the guidelines and recommendations that have come out over the years. And I'm going to mention the development of the baby sleep information source. So starting off with the provision of bed sharing information, and particularly for breastfed babies, the key relationship that we've had on this one from the very early days has been with Unicef UK Baby Friendly Initiative. And they've really been the key driver in this country about changing conversations around sleep and breastfed babies. And you can see here, I've put an image of the evidence and rationale document for the Unicef Baby Friendly Initiative standards, and in section 4.5, which is about supporting parents to have a close and loving relationship with their baby. Much of it is about what's happening at night, caring for the baby at night, baby's sleep behaviours, where babies sleep, bed sharing and breastfeeding. And this is where our research has been able to contribute to the information that Unicef uses for its standards and also trains health professionals in, etc. So the relationship that we've had with the Baby Friendly Initiative has informed the guidance that Baby Friendly give to parents, such as the Caring for Your Baby at Night leaflet, which is commonly given out when parents leave the hospital after having had their baby in this country, and the Health Professionals Guide, which provides all of the evidence base behind the parents' information leaflet. Over the years, Baby Friendly has produced a lot of different guidance. This was one that was published fairly early on, but I put it up as an illustration of how many languages. So it's been translated into many, many languages so that all of the communities in the UK that health professionals work with have access to this information, which has been really important. And it also means that these UNICEF produced guidelines get exported to other countries as well and used in other countries where these languages are relevant. Another organisation that we've worked with extensively over the years has been the Leche League, particularly Leche League GB, who also produce information for breastfeeding mums about things like sleep and the breastfed baby. And we've, over the years, they revise this information and come to us for the latest research, which we're able to kind of insert into these information sheets and make sure that what parents are receiving is the most up-to-date evidence on all of these kinds of topics. The second place where our research has gotten used over the years has been in hospitals, and there is such a thing as a hospital bed sharing policy. Sometimes they're incorporated with hospital feeding policies. And these are just a few examples of ones that I've received over the years. And the little bit of text that I put at the bottom there just illustrates that the midwives and health professionals who are charged with creating these policies draw upon the information that we produce. And this was particularly the infant sleep information source, which was the name of the baby sleep information source before we changed it, for reasons which I'll leave to your imagination. I'm sure you can figure out why we changed the acronym. So they're drawing upon the materials that we produce to inform their policies and their practice guidelines. And then they often send these documents to us to have a look at, to make sure that they've been citing the research accurately, etc., which means that we have the opportunity then to kind of make sure that our research is being implemented in practice in an appropriate way. This notion of having bed sharing policies that help mothers and babies to stay in close proximity on the postnatal ward in a safe way, with midwives who have guidelines around how frequently to monitor mums and babies, which circumstances are inappropriate for babies to be in bed with their mums, etc., has also been picked up gradually by the American Academy of Pediatrics. And in fact, our hospital studies were highlighted in the American Academy of Pediatrics clinical guidance on safe sleep and skin-to-skin care in the neonatal period. So you can see here, they used an illustration from one of our PhDs of the sidecar cribs that we've been trialling in the RVI in Newcastle, and talk extensively about how the provision of these kinds of sidecar cribs can improve breastfeeding outcomes. And in the States, this is a particularly big step for them to take for two reasons. One is because they advise against bed sharing at home, and the other is because there are still a lot of neonatal nurseries in American maternity hospitals, and babies are just taken away to the nursery and not kept in the mum's room. So the recommendation to keep the mum and the baby close and to use something like a sidecar crib is a really big step for them. The third thing where our research has been used is in thinking about this alignment of babies' biological needs with parents' lives means that parents pursue different sleep strategies and have different information needs in that regard. So this has challenged some of the previous guidance that was out there about bed sharing and telling parents never to bring their babies into bed because there are risks associated with it, particularly in some circumstances. And it's moved people along the route to thinking about what parents' actual needs are. And it's not helpful to tell parents that they must do something or must not do something. Our research has illustrated that it's much more effective if we can listen to what their needs are, offer them information that is appropriate to their needs, be non-judgmental, and help them to discuss these things openly and make choices that are safe for their baby and are right for them. So you can see in this safer sleep strategy from one of the safeguarding boards how they're reflecting these arguments in their safer sleep strategy and citing the research that we've done around these issues. So that means, you know, that the work that we've done is actually being implemented into practice and is changing the conversations that people are having with parents about infant sleep and infant sleep safety. And this all really kind of culminated, came to a crescendo in 2014 with the NICE review of SIDS and co-sleeping, where the conclusion that was reached was that the way forward in the UK ought to be to empower families to make informed choices about these issues, not to issue one-size-fits-all guidance that just tells parents not to bring their babies into bed. So the NICE guidance recommended that we give parents information about what makes bed sharing hazardous, but also tell them about the benefits of it and have informed conversations. So as a consequence of that, we worked closely with the Lullaby Trust and Unicef to produce this infographic on co-sleeping and SIDS that tried to do exactly what the NICE recommendations advised, which was to inform parents about the risks, the fact that the risk of SIDS when sleeping with a baby is greatest if you do it on a sofa, or if you've consumed drugs or alcohol before doing it, that there is a risk associated with smoking. But in the absence of those risks, the chances of something untoward happening are very low. And the proportion of families that do end up bringing their babies into bed is so high that on any given night, over 20% of babies will be in their parents' bed. So that's something like 150 odd, 100,000 babies will be in bed with their parents tonight. So we have to have conversations with parents about it in order to make it clear what the risks are and how to avoid them, as well as telling parents about the benefits, which they usually figure out for themselves, which is why the babies end up in the bed in the first place. Similarly, we've worked with the Twins Trust and Lullaby Trust to produce safer sleeping guidance for parents of twins. And this wasn't so much about bringing the babies into bed. This was about putting multiple infants in the same sleep space which is a strategy that parents of twins often use in order to keep the babies in their own bedroom, in the parents' bedroom, because there isn't usually room in most people's bedrooms to have 2 full-size cots. So if you put your babies in the same cot, then you can fit them in your bedroom for longer, which is something that reduces the chance of SIDS. But then how do you do it? Do they need to be opposite ends of the cot? Can you put them side by side? What happens if you've got triplets and all of this kind of thing? So we've done some research with parents of multiples, which we use to inform what the guidance that the Twins Trust and Lullaby Trust give out to parents of multiples regarding safer sleep. And then, of course, we have worked in direct co-production of interventions with NHS trusts. So the one I'm going to use to illustrate here is Blackpool and Lancashire NHS trusts wanted a discussion tool that they could use in antenatal conversations with parents or with mothers particularly, to help them think about where their baby was going to sleep before they'd even given birth. So together we designed this Where Might My Baby Sleep leaflet as a tool to support negotiated face-to-face education that could help providers give information to parents and help parents think through some of the issues around where their baby was going to sleep before they brought it home from the hospital. So in the middle of this tool, we devised this thing called the bed sharing decision tree, where parents were asked certain key questions that might encourage us to have them think again about bringing their baby into bed, because it might increase the risk for the baby. And this then led parents to kind of understand what the answers were. So we were very keen not just to tell parents, you should do this, you shouldn't do that, but to explain to them why they were being given the information and guidance that they were being given. What happened following the production of this Where Might My Baby Sleep leaflet, was that it got picked up by the Public Health Department or the Perinatal Services Department in British Columbia in Canada, and they adapted it to create their own decision tool, which, you know, it looks very similar to the one that we had produced. It's got the same questions, it's got the same kind of explanations, but it's being implemented in a completely different context in another part of the world. They use some of our imagery about the way in which mums and babies sleep together, etc. So, you know, what this illustrates to us is even when we work on a local level, sometimes that local co-production of information and engagement translates around the world, and other people pick it up and start using it to create their own information. So it spreads. Once it starts rolling, it sort of takes on a life of its own. And fourthly, so the incorporation of the research that we've done at Durham into guidelines and recommendations. So these are some examples of guidelines from around the world. So the Academy of Breastfeeding Medicine's Bed Sharing and Breastfeeding Protocol. Academy of Breastfeeding Medicine is an international organization of clinicians who work with breastfeeding mothers. So they've produced a document about the relationship between breastfeeding and bed sharing, and how clinicians around the world might have conversations with parents depending on the different circumstances that they're in about this issue. And that involves a lot of the work that we have done over the years. Likewise, the New Zealand College of Midwives and the Australian Breastfeeding Association produced their own documents, again, for their own local populations that are informed by the kinds of research that we've done both in hospitals and in the sleep lab around why parents bed share, how parents bed share, what we need to talk to parents about, what they need to be thinking about, etc. But probably the thing that I'm proudest about really is the new guidance that came out in the UK in 2019 where we worked in collaboration with the Lullaby Trust and Unicef Baby Friendly and Public Health England to produce new national guidance for conversations around safer sleep for babies in this country. So I'm going to talk to you in a little bit more detail about this one because it's relatively new. People aren't as familiar with it. And also because we were involved from the very design stages all the way through. So it's a nice story to be able to relate. So one of the reasons why we wanted to produce this new national guidance is because of the way in which SIDS, sudden infant death syndrome, or unexplained infant deaths, has fallen over the course of the last 30 years in the UK. So this is a story that is common to most Western industrialized societies, that SIDS rates were very high in the 80s and the early 90s. People figured out in the 80s and early 90s that putting babies on their backs rather than their fronts when they sleep dramatically reduced the chances of babies dying suddenly and unexpectedly. So back to sleep campaigns were introduced all around the world, and SIDS rates fell quite precipitously. And this is the fall in SIDS rates in the UK that you can see here. As a consequence of this dramatic fall in SIDS rates, and there's other guidance that parents have been given about safer sleep, as well as putting their babies on their back. But as a consequence of all of the guidance that's been implemented in the safer sleep campaigns that have happened, today's parents giving birth now, don't have very much, if any, first-hand experience of sudden infant death. When I was a child, I can count probably 4 families in our immediate community that I knew as a child had lost a baby to sudden infant death. Nowadays, my daughters, who are in their 20s, don't know anybody who's lost a baby to sudden infant death. So reducing the risk of cot death, just, giving them a leaflet that says, here's how to reduce the risk of cot death, isn't compelling to them because it isn't an issue that has affected them in their lives or anybody that they know. So we need to think, or we decided that it was really important to think about the way in which we give that information to parents now compared to how we gave it to parents 30 years ago. So when we did our research in Bradford, the Bradford Infant Care Study at the end of around 2010, what we found was that South Asian mothers in our study believed that SIDS guidance, the safer sleep guidance, didn't apply to them. It only applied to the English mothers. And they felt that it only applied to the English mothers because it didn't reflect any of the practices that they implemented in taking care of their babies. It talked about smoking, and it talked about not putting your baby in a room by itself. And these were things that South Asian mothers didn't recognize. They didn't do those things. So they thought the guidance only applied to the English mothers. But when we talked to the white British mothers, they argued that it doesn't apply to mothers like me, because I've got a baby who's a good sleeper, therefore I don't need to keep it in my bedroom because I don't have to respond to it frequently in the night. So it's okay to put it in a separate room when it's 3 months old, etc., even though the reduce the risk of cot death guidance encourages you to keep your baby in your room for the first 6 months. So parents found lots of arguments, or increasingly found lots of arguments for why reducing the risk safer sleep guidance didn't apply to them. They also found the long list of safe sleep messages that had accumulated over the years quite overwhelming, and some of them were quite difficult to implement. They also told us that they objected to being given guidance without any explanation, not knowing why they were being told to do certain things, they were just being told to do it. And they rejected idealized recommendations such as you should always put your baby back in a cot after you've breastfed it, because they didn't fit with their lived realities. When you breastfeed a baby, you often fall asleep in the middle of doing so. So, the idea that you're going to wake up and put your baby back in the cot at the end of a breastfeed every time is rather an idealized kind of recommendation. And they also wanted to know that if they couldn't attain what was the safest sleeping arrangement, what was safer? You know, out of all the other things that they could do, what was safer when the safest wasn't attainable? So this was the backdrop against us producing this new guidance. This was why we produced it. And what we aimed to do was provide guidance that was consistent with the NICE guidance, including parents' right to make an informed choice, not just be told what to do. We wanted to streamline the guidance to focus on the key risks as they pertained in the UK based on the most up-to-date UK research. And so that meant shortening the list of things that parents had to remember to do to just the really important ones. We wanted to be responsive to parents' concerns and help them understand the reasons for the guidance that they were being given. And we wanted to prioritize avoiding the most hazardous sleep practices that contributed to the greatest proportion of infant deaths. So we emphasized putting the baby on his or her back in a clear, flat sleep space and keeping them smoke-free day and night. And Public Health England sponsored these materials and they approved the approach that we were taking. One of the things that we chose to do was to retire a phrase that had been used extensively in safer sleep guidance in the UK for many years, and that was the safest place for your baby to sleep is in a cot by your bed. And the reason we retired that phrase was three reasons. First of all, our research had found that parents were interpreting this guidance to mean that you should always put your baby in the bedroom for daytime as well as nighttime sleep. And that is actually counterproductive because what the guidance meant was keep your baby where you are, not put your baby upstairs while you're downstairs. So people were misunderstanding or it wasn't a clear message. Secondly, the assumption that all babies sleep in cots and that Western bedrooms and budgets can all accommodate a cot is a very middle class sort of assumption that centers Western cultural assumptions about where babies sleep. Lots of babies never have a cot, and parents need to know how to make whatever their baby's sleep space is safe, not just be told to put it in something that they can't purchase or accommodate. And finally, many families now use sleep spaces that are neither cots nor separate, like the bedside cribs. So we wanted to get rid of that phrase, and we used a clear, flat sleep space to try and eliminate some of these assumptions that were misleading and alienating families. So this is an image from the inside of the leaflet, and that we've got the three clear, simple messages on the left here. The guidance is accompanied by explanations labeled reasons, so that parents understand why the information they're being given is there, what its purpose is. We emphasize keeping the baby smoke-free and breastfeeding because they both strongly lower the chance of SIDS. Co-sleeping is a complex parental behavior, as we've talked about, or bed sharing, which can increase SIDS and can increase accidental infant deaths, depending on the way in which it's practiced, whether it's done more or less safely. And the UK Child Safeguarding Review in 2020 concluded that it was both too common and too complex to apply a simple ban. So we decided we needed to give parents information about how to do it more safely as possible. So it prioritizes what happens during bed sharing and how to make the baby's bed sharing environment safe, which encourages people to have open discussion and share information and plan ahead. And we particularly emphasize why sleeping with a baby on a sofa is much more hazardous than sleeping with a baby in the bed. So the practitioner's guide that accompanies the National Safer Sleep Guidance offers information on having non-judgmental conversations with parents, personalizing the information, emphasizing the contextual risks, so what's going on in this family that's not going on in that family that might need thinking about. In a pilot evaluation that we did of these materials, parents who initially denied bringing their baby into bed with them were willing to talk about it after they'd seen the leaflets and realized that it was a topic that they could discuss. So that was it, you know, exactly one of the things that we had found previously in our research, that if parents are encouraged to talk about bed sharing, then they'll tell their health professional that they've done it. But if they think they're going to get told off, then they just won't discuss it. So this means that practitioners and families can have meaningful conversations about reducing high-risk situations. We've also devised with Lullaby Trust a program of training for practitioners who want to increase their knowledge and confidence. So in having these conversations, because obviously it's something they've not been trained in over the recent decades, when they were encouraged to just tell parents not to do it. So the next step, I do this every time I give a talk. I have my hand on the mouse and then I advance the slides too quickly, sorry. So the next step that we are thinking about is a systematic evaluation of how practitioners and parents receive and engage with these materials. So we've got some funding now to undertake that evaluation. So that's going to be the next step in establishing the evidence base for how well this all works. To wrap up then, the other thing that I just want to mention is the creation of the baby sleep information source. So as we were producing all of this research and it was being used by people to kind of change practice and policy, it seemed to us like a good idea to have all of the information in a one-stop source where people could access it. So we were funded by the ESRC to create this resource, which is a website primarily, which has information about how babies sleep, where babies sleep, sleep and safety, and twin sleep. So all the things that we've talked about this lunchtime. We produce resources for parents, some of which I've obviously introduced. We produce resources for practitioners, including things like our information sheets on different topics around infant sleep that they can print off and give out to parents in antenatal classes, postnatal classes, home visits, wherever is useful. These are some examples of those information sheets that we produce. And the baby sleep information source resource has been very positively received. It's been very nice to see the kinds of feedback that we've been getting on our social media pages. So these are just some reviews that have been left by people who've used it on our Facebook page. People who appreciate the kind of scientific background behind the information that we're producing, people who use it in practice in public health, maternity nursing, parents who've come across it who were worried about something to do with their baby's sleep, and it's reassured them or helped them realize that what they're doing is okay. So in one of the ways in which we have brought this to the attention of health professionals and parents is by a lot of old-fashioned standing around talking to people at conferences, at shows, you know, at venues where health professionals and parents congregate. But obviously over the course of the last couple of years, like everybody else, we've had to pivot to more online ways of communicating, particularly with health professionals. So we've set up our own online training platform where we deliver our webinars to different NHS trusts, and we occasionally open them for kind of public registration so that health professionals whose trusts don't have us do training for a whole group of people can come and do their own training if they want to. So information about all of that is available on our website. And as was said in the introduction, all of this has kind of culminated in a couple of awards that we've received, one from the SRC, one when we got to go and swan around in our academic robes at Buckingham Palace, which was very nice. But that's not really the reason why we do all of this. The reason that we do all of this is that we wanted to make a difference, and we wanted to make a difference for parents and for babies in the UK. So hopefully I have persuaded you over the course of the last 40 minutes or 45 minutes that we've had some impact, that we've managed to influence policy and practice to some degree in the UK and further afield over the past 25 years. It is possible to change policy and practice, but it's a long slog. It can take a very long time to see evidence of change. So you've got to be persistent. Sometimes it's explicitly recognized with fanfare. Sometimes that change is quiet and subtle and you have to really look for it. But what has helped us particularly is establishing mutually beneficial relationships with organizations that are working in the areas that we've wanted our research to make a difference to. So UNICEF, the breastfeeding organizations, some NHS trusts, we've had particularly strong relationships with over the years. Some other relationships have taken time to develop. So at one time, Lullaby Trust and we were on opposite pages, as with the safeguarding boards, but things, have gradually over time come closer together, and we've been able to work together, which is very promising. So there's much work still to do in normalizing infant sleep behavior and promoting responsive nighttime care, but I feel positive about the future. I think things are moving in the right direction. So I will stop talking and let those of you who have questions have an opportunity to get those questions answered. Thanks very much.